hello everybody, thank you for coming to this workshop. My name's Elizabeth Beech. I'm the National Project Lead for Antimicrobial Resistance at NHS England and NHS Improvement, because we are now co-joined. Susan Bowler from Nottingham University has kindly agreed to do some shared learning from some improvement work they've been doing associated with the with management of UTI, in particular with a focus on this year's sequin. So I'm just going to kick off and give you some feedback about the learning from the sequin this year and what we've got planned for the next financial year, and then we'll hand over to the very interesting stuff from Sue, which is the sort of stuff you might want to take away with you. You can happily tweet, as you have been doing all day, with that hashtag. So my Twitter handle is @elizbeech if you want to tweet from me. So the sequin scheme we have running in this financial year, we have two antimicrobial resistance focused sequins. We have lower urinary tract infections in older people, and we have antibiotic prophylaxis and colorectal surgery. They both sit under prevention of ill health. And I'm assuming all of you are sort of familiar with the sequin because you have come along to this session. But before I give you a bit of a reminder about what the sequin ask was, I'd just like to remind you that the sequins, both this year and next year's sequin, are very much aligned to the UK National Action Plan for AMR. So these are some of the ambitions, not all of them at all, but some of the ambitions from the National Action Plan, with a focus to reduce specified drug-resistant infections, to halve, as I'm sure you all know, the number of healthcare-associated gram-negative bloodstream infections, and focusing on improving the management of UTI is very much one of the ways of supporting delivery of that ambition. Reducing antimicrobial use in humans that's inappropriate or not necessary, and again the sequin tries to promote appropriate use of antibiotics, and reducing the use of the reserve and watch, the broader spectrum antibiotics. And lastly, reporting on the percentage of prescriptions supported with a diagnostic test or a decision support tool by 2024. And this is because we know whichever sector you're working in, diagnosis of infection really has a lot of room for improvement. And that is why the sequin this year and next year have got a focus on the diagnosis and trying to drive improved diagnosis. So the sequin this year specifically is focused on improving the management of lower UTI in older people. And this has really been pushing improved diagnosis using clinical signs and symptoms, not treating the dipstick, which really should not be used as part of the diagnostic process for UTI in older people, because they're likely to have bacteria present, or there's a 50% chance they'll have bacteria present or not. And as a microbiologist said to me a couple of years ago, save your dipsticks, throw a coin, go heads or tails if you really want to use that sort of diagnostic approach to whether an older person has a lower UTI. But I think that sort of sums up the need to look at the patient's clinical signs and symptoms. So this has been also aligned to the new NICE antimicrobial prescribing guidance for lower UTI, and it's also trying to increase the urine sample sent to from microbiology. And this is in case of treatment failure, because this group of patients are at much higher risk of having a resistant UTI than your younger patients. So this is preparing for a treatment failure down the line. Now, the challenges with this sequin have been the sequin rules require retrospective sampling of 100 cases for sequin compliance purposes, and this is based on codes. And the ICD code for inpatient care is N39 and N30, and they're very non-specific. It covers sort of UTI or suspected UTI. And I know there's been a lot of pain and grief around the country sifting through records, trying to find those lower UTIs that are compliant with the sequin. In ED, where there are SNOMED codes, it's been a little bit easier, but otherwise it's a very generic infection ED 27 code, and that's terribly difficult as well. So there's been a lot of stakeholder engagement developing the next sequin for next year to try and reduce some of this pain. The sequin is supported, in case you are not aware, by resources published currently on the NHS Improvement website. These include frequently asked questions, which are updated following all the questions, the queries that come in through the life of the sequin. So do remember that that's a resource to check every so often. And it also includes the data audit submission tools. And again, those are the tools you should use rather than obviously making up your own. I know Public Health England, who take the data, the audit data submissions, have had people do some horrible things to the data, the Excel workbooks, and change them and muck up the formulas. They are designed so that you just enter your data from a drop-down list and it auto-calculates everything for you. So I put a plea out to whoever is doing that to please not muck up the data tool, because it just gets bounced back to you. In terms of how are we doing, well, I think the answer is probably badly. Q1 has now been disallowed because it was so chaotic. The sequin came out very late. People were really struggling with that coding issue and didn't have quality improvement programs set up. And so I'm very pleased that Q1 has been disallowed for this particular sequin, just this sequin, not the colorectal one. The data is published quarterly on Fingertips, but the reason why there's not a lot of data there, and you can see that's a small number of trusts, I mean, sequins are voluntary, but I know more trusts than that are doing it, is because of some of the data quality issues, because the data submitted has had to go back because it's not correct. And that goes back to my plea to please check your data hasn't been mucked about by whoever's submitting it, and that it really does add up. So this will improve when PHE do their next Fingertips update, because they will back publish Q2's results. So we are expecting to see that look much better. I get a copy of the data, the good, the bad and the ugly, that PHE won't publish on Fingertips. So I know in Q2 there were about 6,500 patients' data submitted, which is a lot of data, isn't it? And of that, we're getting it right first time for 40% of patients. So I don't know if anyone in the room thinks that's reasonable, but if it was, well, I'm not quite 65, but hey, when I get to 65 and it's my UTI, I would really like not to be 6 of the 10 people who are not getting it right first time. I really, really would. So I'm hoping we'll have improved by then, but obviously it's not great for patients now. When we look at the performance on a regional basis, there is a north-south divide. And I'm pleased to say that those trusts who did submit Q1 data, that we have had improved performance submitted for most trusts in Q2, so that's great. With the biggest improvement from the Midlands and East region. So anyone here from Midlands and East, stick your hands up. Yay, well done. And in terms of actually meeting the 60% where payment for the sequin kicks in, 20 out of 88 trusts had met that in Q2. So there's and only 2 trusts had got over 90%. So I know the Q3 results are looking better. I've been told by lots of people they're really pleased. They've seen improvement. And from an improvement point of view, we are looking for continual improvement. So this was very, very painful for everybody. So next year, next year's sequin. We wanted to focus on catheter-associated UTI, but we were going to hit the same coding problems. So after lots of stakeholder engagement, and thank you very much if any of you are in the room, I really appreciate your honest feedback and your help and your thoughtfulness. We have made some big changes, and we've now decided to go for all UTIs in all adults that are acute, so recurrent UTIs excluded from this. This resolves some of those issues with the coding, because you're looking really for everybody that lands under that code. We've also worked with the emergency care data set and NHS Digital. We've got a new SNOMED code for catheter-associated UTI. So people landing in ED with a CAUTI will be coded CAUTI for the first time. That's really helpful because it starts to build up some data for those patients who do have CAUTIs, because we know that's one of our big risk areas for healthcare-associated infections and for E. coli bacteremias as well. The other thing you'll notice is the payment thresholds have been lowered. So these will be easier to achieve. So the minimum threshold is 40%, not 60%, and full payment will land at 60% and above, not 90%. All All of the guidance that people are being steered to are the NICE antimicrobial prescribing guidance. So we have NICE antimicrobial prescribing guidance, which is what launches inclusion in the sequin for lower UTI, as in this year, for COUTI and for pyelonephritis. We've also included anyone with urosepsis, because again the stakeholders said, well, we don't sepsis code them, they're coded UTI. So rather than worrying about including, excluding, sepsis is in there as well. So really, what's excluded are pregnant women, patients prescribed antibiotic prophylaxis for the treatment of recurrent UTI, they are excluded because that's a whole different issue, and chronic tubular interstitial nephritis. And we say that because the pyelonephritis codes do include that as one of the disease categories. We haven't got a more specific code. So what is new here is that the 5 process points, there were 4 process points this year. The 5th point is for diagnosis of COUTI, there needs to be documented review of urinary catheter use in the notes. That's going to be challenging. Anybody know if a catheter is documented in the patient record, if they have a catheter? Should be. So some of the stakeholders who went away and had a look for me came back and said, actually, it's not. It might be on a separate bit of paper somewhere. So I think that will involve some thoughtfulness about how that's going to work. It's not going to assess you on what you do with that catheter. So the options will be do nothing, leave it in, do nothing, take it out and replace it. It's already been taken out, or don't know. If you say don't know, no documented review, that will be a fail. But if you do any of the others, that will be a pass. We're not dictating what you do with that review. We just want the start of a process whereby it's thought about in the context of that patient's UTI. So some sequin savvy top tips. Really, obviously, you are probably, I hope, likely to know who your trust sequin lead is, but do find out. And sometimes it's better to, rather than wait to be done to step up and say, we can help here, we can lead this, we can do it well. What exactly is the ask? I know there are real challenges with getting resources out of trusts to support the improvement work that's necessary to deliver the sequin. And I would say, well, very, very good use of this year's data to show maybe where you haven't met the sequin because you haven't been resourced. Yes, you've done some improvement because it's the right thing to do, but you haven't actually met your sequin targets. Well, you know what? If you gave us some decent resources, we might do better this year. So think about that, those of you who are in that situation. Clinical leadership is totally essential. You need to identify your stakeholders and champions. I think you definitely need to think about the continence team for moving forward for next year's sequin, or whoever's managing catheters, and how that's going to work. And definitely befriend the quality improvement team if you haven't already done so, because they may be able to help you with your improvement planning. Data is essential because if you can't measure it, you really have no idea what you're doing. And I mean data for improvement, not data for sequin purposes. So very much would emphasize you need to look at this as an improvement program for sustained improvement in your organization, not just as a sequin one-year event. Lots of communication and lots of innovation. I mean, it is called a commissioning for quality and innovation. It is, encouraging innovation. So I'm now going to stop and move on to the innovation and sharing the success and sustaining improvement the Nottingham University hospitals have done. They've been having a very big focus on improving the management of UTI irrespective of the sequin. And I'm going to pass over to Sue to talk about that, and we'll hopefully have time for questions at the end.
Lovely. Good afternoon. So I've been kindly asked to talk to you about the quality improvement work we have undertaken in Nottingham around improving the diagnosis and management of lower UTIs. I think it's really important to acknowledge that a huge amount of quality improvement work around UTIs and the urine dipstick was undertaken prior to this year's current sequin. And the driver for this was that our local audits frequently demonstrated that urinary tract infections were being overdiagnosed and overtreated. And it was the dipstick that was frequently used to justify the diagnosis. So for this reason, for World Antibiotic Awareness Week 2018, Following changes to our AKI guidance and sign-off from the Nursing and Midwifery Board and Medical Director, we launched no longer performing routine dipstick on admission for our adult patients. So to dip or not to dip, hopefully everybody is really familiar with that, a really fantastic quality improvement work that's been led by Elizabeth, which aim to improve the diagnosis and management of urinary tract infections in older people living in care homes, and successfully demonstrated that we can safely reduce antibiotic usage by changing the way we diagnose urinary tract infections. And that piece of quality improvement work was then carried out within Nottinghamshire care homes as well, and we work really closely with our community antimicrobial stewardship team. So what we decided to do was take that piece of community work and for the first time bring it into the hospital setting. So what we did, we got a linen trolley, we loaded it full of resources and freebies, and we took it to as many wards as we could during World Antibiotic Awareness Week, and we asked our frontline staff to undertake the to dip or not to dip challenge, and you can see we used the to dip or not to dip paddles to encourage engagement. We had front door promotional stands, and we also, prior to this, we've done a huge amount of work looking at rejected specimens with our nurses, and we kind of moved a step further to involve our scientists working in the lab. So they came up and I've done some training with our nurses as well. So we really value the impact of rejected specimens, not only on our colleagues working in the lab, but how that impacts on patient care. At the same time, there was quite a lot of quality improvement work going on. One of our HCOP registrars was looking at a piece of work, looking at nurses' attitudes and behaviours towards urinary tract infections and dipsticking. And also, as part of the NHSI UTI collaborative, we did a piece of work with staff on our HCOP admission ward, again looking at dipsticking behaviour and their levels of knowledge as well. Just wanted to show you this and how fantastically this works. This just shows a great engagement we got from using kind of this approach. I did get known as the dipstick nurse for a little while, and here again. So if we move on to the current UTI sequin, it was really important to us as an antimicrobial stewardship team that if we were going to support with this sequin, that actually the lead for the sequin was a HCOP consultant, because actually that's where all the majority of the quality improvement work was going to be undertaken. And actually, absolutely, we'd learned from previous work, it had to be interprofessional engagement or it just doesn't work. Finding this right person did cause a little bit of delay to our first task and finish group, which started in June. But while that was being agreed, we were kind of actively looking at our UTI guidance, bringing it in line with NICE, and we made the change to our diagnostic and treatment algorithm for the over 65s to no longer dip, which actually was a much clearer, much simpler message to take to our frontline staff. Trust-wide comms, really important. We came up with the Think UTI, Skip the Dip slogan, which is really well recognised. I'd like to think that if you went into any ward of our wards and said what Skip the Dip is, people would be able to explain what it's all about to you. Think UTI, really important, because we don't want to have any conflicting messages with the AKI team. So it's still really important to dip in the over 65s when patients have evidence of AKI. So we wanted to acknowledge that. And Skip the Dip was a move away from the question to dip or not to dip, because actually in this age group now, we were no longer going to dip. So we wanted them to think about Skip the Dip. So all our communication, be it by posters or screensavers, we made metal pin badges in the shape of a dipstick, had stickers and pens, all followed those 4 elements of the sequin to constantly remind frontline staff, and they had something they could refer to. Reminder cards, these are so popular within our trust. I don't know if any other trusts have used them. Really simple. And we use these to focus as for our junior doctors' inductions, and they can hang them from their lanyards. So it's just a quick reminder of the key messages. And actually, as you hand them out, it gives you an opportunity to have a quick conversation about best practice. So I've developed the kind of skip the dip training for our nursing staff, and I deliver most of this training throughout the trust. But we also this year looked at a train the trainer approach in HCOP. Now, to do that, because UTIs aren't that simple, we use the health education video, which just the middle part of it, which is a really good thing to use because it really simply explains what a UTI is. It talks to staff about the significance of having bacteria in your urine and helps them to understand, which is really important if you're going to see a behavioural change, why they shouldn't dip. And actually then if I'm not there, they can play that video to the staff. We always use patient scenarios at the end of any of our teaching, and this is really important to take that theory, that new idea, and apply it into practice. Because often, although we've said we've changed our guidance and we're no longer dipping in the over 65s, you come to this first scenario where Arthur is 70 and most people still want to dip. Okay, so it's really important to have the patient scenarios as well. We also went one step further in the HCOP wards, and we decided, with agreement from the HCOP consultants, that we were going to remove the current dip and replace it with a dip that had no nitrites and leukocytes on it. Trauma and orthopedics were also really keen to have an alternative dips, and that they now have 2 dips. One for the over 65s and one for the under 65s. Now, we haven't rolled that out to the whole of the trust. It's working for them because A, they wanted it, and B, they were really engaged and had a high level of knowledge. This was World Antibiotic Awareness Week this year. So our focus, it was fully sequin focused on the UTIs in the over 65s. Again, similar approach. We took our training and resources to the wards. You can see at the bottom in the middle there, it's one of our biomedical scientists doing the specimen training with our nurses. We rewarded any staff that had gone the extra mile for us with our bug hampers. And also we launched our reusable learning object, which I'm going to talk to you in a little bit more detail in a moment. So very simple resources. This was put together by one of our clinical pharmacists, and you can see it in action there. And just another one was a really popular symptom sorter game, really getting everybody involved. I can see smelly urine in that person's hand there in the corner. So just very simple resources, but always taken to frontline staff. Okay. So this is our reusable learning object, and it takes you on a patient journey. It's open access, so please take a look at it. It takes 15 minutes to complete, and if you like it and you would like to use it in your trust in support of next year's sequin, you're very welcome to do so. Just so you get a hint, I don't want to spoil it for you what this is about, I'm just going to read you the opening sentence. So, hi, this is Florence. She's 74. She's had a bit of a fall at home today. She's been found by her neighbour and they said there's a strong smell of urine. Okay, I'll leave it there for you. So it encourages the learner to interact with the content, which is really important aspect of learning, and it uses reflection. So it asks you what your thoughts are on Florence diagnosis, and it also asks you whether you would recommend antibiotics. As we go through the scenarios become more complex. So you click on these little scenarios, on these little circles, and you get more and more information about what's happening to Florence. So decision making becomes a little bit more tricky as you go through. But there are also some very practical elements to it. So you have to send a specimen. You have to make sure that you send in the right container. You have to fill it in with the right amount of urine because it won't go anywhere otherwise. And you have to securely put the lid on, so to kind of support all the work we've done in the trust around rejected specimens. Next steps, we want to make this mandatory for all our staff within our trust as our antimicrobial stewardship training, because although it talks about a urinary tract infection or potential urinary tract infection, the principles can be applied to many different infections. We've already had the green light to make it mandatory for pharmacists and non-medical prescribers, and I'm hoping to get it mandated for nurses as well. We want to make it even more accessible for our frontline staff. So the aim is to have a link on staff work mobiles so they can access it directly as well. So there's no excuse to not complete it. So the challenges of the sequin as well, I think it's important just to touch on those. So whatever we do, we need to make sure that it's a safe approach and that it's sustainable. And I think the RLO is a great example of how we're going to sustain the work that we've done. Fundamentally, absolutely, it requires an interprofessional behavioural change. And also we need to manage patients' expectations and relatives' expectations within this. And yes, for all our patients, we want to treat them holistically, but there's massive pressures on clinical staff to make that diagnosis, to make that treatment, to give that treatment, to send them home, and that's really challenging. UTIs are not simple. The message is complex, and the interventions need to be multiple to make a change. We've done a lot of work not to provide a conflicting message to the AKI agenda, and that's really important. It should be considered at all stages. We as a trust don't have e-prescribing, so it's really difficult to identify these patients with a simple UTI. It's difficult for us to identify if there's any inappropriate treatment and make timely interventions. Human resources, it's been a real challenge to us. We're a small antimicrobial stewardship team in a huge trust. We've done all the auditing, the coordinating, all the quality improvement work as well. And finally, Elizabeth touched on this, but actually finding these patients that have a simple UTI for us has been really challenging, really high exclusion rates. But also within our trust as well, many of the patients that would have presented to ED get filtered away, appropriately filtered away from our trust. So this is our progress. So our baseline is Q1, that's no longer been included, and the final results are our Q2 and 3's performance. And I think one way of thinking of these different elements is to think of it as like a care bundle. And actually, yes, the gold standard, as Elizabeth said, that for all our patients, we want them to receive all this. But actually, making improvements in these individual elements also equally has a massive impact on patient care. So we, as a trust, have agreed local variation. So we will, our final payment will be based on the individual criteria, not as the criteria as a whole.